Hi everyone, I'm Dr. Bhupesh. So I'm a practicing cornea and refractive surgeon in New Delhi. So today I came in AIOS meeting and my talk was on Post-Lasik Ectasia, and the specific topic that I talked about today is intraoperative variables that we can modify during surgery to prevent post-Lasik ectasia and get the good visual outcome after the LASIK surgery. So if we talk about post-Lasik ectasia, there are different factors that affects the LASIK outcome, like pupil size, optical zone, and residual stromal bed, the flap thickness, the amount of myopia that is there, and the amount of corneal thickness that is preoperatively present. So all these variables are interdependent with each other. For example, if some patient is having a high myopia and you have to cut or treat a lot of stroma with the excimer laser, then chances is there that residual bed is low. So if there is a residual bed is low, the chances of post-Lasik ectasia is more. So we have to play around with all these variables to get the good outcome. So if any patient, for example, if any patient is a large pupil of more than 6.5 or 7 millimeter, then what you can do is to increase the optical zone so that the problem of night vision is not there, and the outcome is good. So you can increase the optical zone up to 7 millimeter. Although the conventional practice is that optical zone is usually between 6 to 6.5 millimeter. Like the other thing is residual stromal bed. So it's conventional understanding that the residual stromal bed should be more than 250 micron. But there are many studies which talk about that residual stromal bed can be increased up to 300 micron, although reducing the RSB or residual stromal bed less than 250 is not advisable. Then coming to the optical zone I've covered, then residual stromal bed. Another important factor is the flap thickness. What flap thickness you're going to give to a patient. For example, with the femtosecond laser, you have a ability to make the flap of up to 90 micron or up to 120 micron. But with macrokeratome blade, the flaps are usually thicker, and sometimes due to faulty techniques or because of wrong selection of suction ring flap thickness can go up to 150 or 160 micron, and that is a point when it can make the patient more prone to develop post-Lasik ectasia. So flap making is very important, and there are different studies that have shown that femto flap is much superior than blade flap, and the variation with the femto flap is just up to 5 micron in almost all the cases. Whereas if we talk about the variation of more than 20 micron in around 42% of the cases which has been done with microkeratome blade. So again, femtosecond is much superior. And once you diagnose post-Lasik ectasia, there are different treatment modalities. If it is progressing, then you have to go for collagen cross-linking. If it is not progressing, glasses or contact lenses works very well in post-Lasik ectasia cases. And the target is not treating the post-Lasik ectasia, target is preventing post-Lasik ectasia to happen. So good planning, good intraoperative modification of different variables can achieve good results, and you can avoid post-Lasik ectasia. Thank you.